I'm so pleased to see all of you here at this hour. I don't know if your family is pleased to see you at this hour, but I am, and I thank you for staying. I want to discuss with you, if I can get this to go, the different biology of the older population and how it impacts on the way we treat this population of patients, and try and impress upon you just how important it is. I'm reversing the pattern. I'm going to show you my very last slide first, for those of you who have to leave early, and just make the 10 important points that we do. First, I want to point out to you that the elderly population is increasing, and it's quite ethnically diverse, and we're going to touch base on that. We're going to distinguish the fit from the frail elderly in making decisions, and also distinguish from confounding diagnoses, which often delay the diagnosis of IBD in the elderly. They have primarily colonic involvement by most studies, but this is being challenged by more recent work. And usually there's a severe first attack with ulcerative colitis and becomes milder, but not true for Crohn's. There's a total difference in immunosenescence. It increases the vulnerability to infection and neoplasia in this age, and it forces us to consider the concept in making decisions to start low, go slow with your medications. And we have fortunate good news that there really is no increased risk of carcinoma with anti-TNFs. There's a paper that just came out 3 days ago in JAMA, which tends to show a slightly increased lymphoma risk, but we will discuss that briefly. The elderly, of course, have higher rates of surgery in ulcerative colitis. The elderly have higher mortality in Crohn's disease, but no difference in surgery between the elderly and the young. And usually that's due to secondary solid tumors. We always test for C. difficile, and I'm delighted that David Benyon is still with us to give us an upgrade on that. But here's a take-home point. You hear a lot about deep remission. You hear a lot about maintaining mucosal healing. I beg you to understand that in the elderly, that symptoms, and I hate to use the word, but symptoms trump mucosal healing. This is a population that cannot be forced into a deep remission at the price of multiple drug reactions. So what are we talking about? There's quite a difference in approaching a family on the left versus the frail on the right. The scope of the problem became apparent at the in the beginning of 2011 with the baby boomers. 10,000 a day are becoming over 60, and 1 out of 3 patients will ultimately be over the age of 60 when they come into your office with the diagnosis of IBD. Most of them in the 60 to 70, a quarter in the 70s, and less in the 80 range. And although only 15% of all of the IBD patients are in this range, they account for 25% of all of our hospital admissions and the greater number of mortality rates and length of stay. So you can expect the senior surge to progress in your lifetime. The epidemiology is above here, but I'm pointing out to you that 60% of these patients are initially misdiagnosed compared to 15% of the younger. And this causes a greater delay in diagnosing this, with often 6 years before the diagnosis is confirmed. The result is a greater mortality and greater comorbid disease complications with this delay. I also want to bring to your attention the ethnic diversity that occurs around the world. This is no longer a disease of Jewish people by the park at 105th Street in New York. This is a disease that reaches every aspect of the globe. The most recent paper showed 15% of all the IBD patients in this Asian population were over 60, and they were tending to be more with C. diff, CMV, and colorectal cancer mortality. In a more recent paper, which was reviewed by your chairman here today, of only almost 8,300 patients compared to 34,000 younger ones, greater colonic disease, inflammatory the fistula, more left-sided colitis, more surgery in UC, and a theme that goes throughout the literature over and over again, the less and unfortunate meager use of biologics and, of course, immunomodulators. An interesting paper on statins in the IBD in the elderly. Sometimes we get some interesting good news that there was a 30% lower incidence of IBD if your elderly patient was on a statin. And this was true for all the formulations, and its effect was strongest in Crohn's disease. And the protective effect persisted even after controlling for confounding covariables. Now, the important series of slides. In the elderly, body fat and gastric pH increases, but the go slow, start low concept is based on the following. The total body plasma volume body water, extracellular fluid, gastric emptying, liver, intestinal transit, and hepatic mass all decrease, as does the glomerular filtration rate, as does cell-mediated immunity, and specific B and T cell lymphocyte populations. What this means is there's less water to suspend the standard dose of drug, and there's a higher toxicity. So, at this cartoon, the blue part is if you look carefully at this, you will see that the concept here of decreasing plasma volume, body water, and extracellular forces you to impact your thinking on weight-based treatment regimens. Now, immunosenescence. We know that with increasing age, the immune system is altered, so there's a greater risk of infection, malignancy, and immune diseases. And malnutrition, which is often overlooked in this population, particularly in our hospitalized patients, will accelerate the decline in immune function. We know that toll-like receptors decrease recognition of microbial antigens, and so there's lesser monocyte cytokine reactions, fewer macrophages to kill the bugs, fewer PMNs, less interferon gamma, decreased plasmacytoid, and the microbiome changes in the elderly, with Bacteroides dropping and facultative anaerobes rising. We know in the adaptive immune system that we all have a thymic involution over the age of 50, and that reduces the naive T cell population, result more viral infection. Less T cells, less IL-2, CD4, and helper cells, the result is an autoimmune and malignant disease potential. And less bone marrow B cells produce a less response to vaccines, fewer antibodies to bind the offending antigens. So clinically, what can you expect? Overall, less bleeding, pain, weight loss, and extraintestinal manifestations. Of course, family history is less, more smoking, and distal disease is more common than pancolitis. But in colonic disease, it is more common, with the exception of a few studies which I'll show you. In this French study, for example, of over 188 patients, primary colonic location, more inflammatory, and at that time, the extraintestinal manifestations were related to more severe disease, and again, the overuse of glucocorticosteroids. In this elderly population, and I'm showing you mostly from 2016, 2017 studies, in this almost 6,500 of these patients, they had increased bowel surgery. So it's not a milder disease. You're going to hear over and over again that IBD in the elderly is milder and you can take greater risks. It is simply not true. The colectomy rate was slightly higher. The Crohn's disease surgical rate was higher, yet perineal disease was less. And strangely enough, they had less arthritis in that study. In this 2017 study, their older patients had more ileal disease than colonic and had much less upper GI disease than the younger patient. But here's an interesting observation, that the remission rate on most drugs was twice as great in the elderly than anticipated in the younger, which was quite a surprise. In ulcerative colitis, younger onset UC patients have more GI surgery, and there was no difference in their remission rates in this large study. So the point being made that there was similar disease behavior between the older and the younger patient. And in a follow-up of 5 years, there was in this population of almost 5,800 patients, there was no difference in disease extent, activity, location, or surgery. Younger Crohn's and ulcerative colitis had greater anti-TNF use, and this is true over and over again. In this population, they compared 98 ulcerative colitis patients. They had 1,700 young. They had 91 Crohn's compared to over 3,400 young. And the clinical course was quite different. Generally speaking, the threshold is lower for hospitalization in the elderly. Not a surprise with comorbidities, the adverse effects of therapy, the simple decrease in ability to handle the disease activity, and yet the elderly also are more likely to seek medical help. Age was the single most important risk factor for in-hospital mortality, and this was primarily due to C. diff, opportunistic infections, and venous thromboemboli. In the differential diagnosis, you're all aware of medication-associated disease, ischemia, infection, neoplasia, and microscopic colitis, but also remember SCAD, or segmental colitis associated with diverticulitis. As far as medical therapy, the steroid-sparing regimens of immunomodulators and biologics are severely underutilized. In this study, a third of the geriatric patients in this hospital were maintained on chronic steroids. Only about 1 out of 4 received supplemental calcium and vitamin D. And this UNC study of over 1,000 elderly patients, much lower, shamefully much lower anti-TNF use compared to the younger patients, and continued glucocorticosteroids. In the EPIMAD study done in France, a large group of one of the largest registries of older IBD patients, as anticipated, corticosteroids and 5-ASA was more frequent than biologics. Okay, but watch this. A third of these 500 patients, over 60, were treated with steroids for a full year, and then at 5 years, almost half of all of that registry patients were on corticosteroids and 3% on biologics. Now the registry was updated just in the past month, and you will see here that there was less rectal bleeding and pain, greater left-sided colitis, but now the thing is similar immunomodulators, glucocorticosteroids, and rates of surgery. Polypharmacy, not uncommon. The elderly take 3 times greater medications than the younger patients, 8 to 10 a day. So I went and I asked one of my patients to go home, line up all of their pills, tell me what you're taking and why you're taking it. And this was a Parkinsonian, and he listed all of what he was taking. This youngster was taking 26 pills a day, which is certainly not uncommon. So the polypharmacy problems are such that this was a study by Ray Cross, who found that with high Harvey-Bradshaw indices and SIBDQs, that half the patients were reporting adverse reactions to their drugs. And simply reviewing the drug list and going over, as he did at every office visit, cutting down the number of drugs, 10% of the patients improved their scores. So the start low, go slow concept, and in the interest of time, to look at the bracketed area, because lean body mass and total body water decrease, and the creatinine clearance decreases, there's a decreased volume of drug distribution, higher blood levels. There's decreased metabolism of drug, higher blood levels, and because of the polypharmacy, there are multiple drug interactions. Dangerous combinations, and this drives me crazy because the patients won't tell you that they're on herbal therapy. In the UK, it was 8% of their population, and they were using 2.5 times greater herbal remedies than prescribed drugs. An example, for example, over there with hepatotoxicity with hypoglycemic agents and statins, using kava. In this country, GI bleeding with warfarin when given antibiotics and ginseng. And actually, the long-term use of herbal remedies in the elderly is completely unknown and unstudied. So what are the challenges? In using 5-ASA as the mainstay in modern UC, you have to remember that we always insist on rectal and oral therapy giving us a bigger bang for the buck, but that's only if the sphincter is competent, and that's not true for 1/4 of the patients who are hospitalized. We know that using 5-ASA at 2.4 grams is comparable to 4.8, except in those patients taking multiple medications, topical medicines, or steroids. And indeed, the poor compliance follows with multiple confusing schedules, polypharmacy, impaired cognition, and dexterity. If you ever try to open your own pill box, don't do it over the sink, please. And limited 5-ASA role in Crohn's colitis persists. Other interactions, well, we know that 5-ASA interferes with ProTime and INR. Studies with warfarin, it increases TGN metabolites. So if you have 2 grams of 5-ASA, you will increase your TGN metabolites by 40%, and it'll go up to 70% with 4 grams. So remember to make the adjustment in the dose if you are those individuals treating with immunomodulators and 5-ASA. Always use the lowest dose possible, and remember the heterogeneity is such that even with an adequate TPMT enzyme, you may still develop leukopenia, so you must monitor your CBCs carefully. As far as the pharmacokinetics, we know very little about the elderly. We know that 1/3 of the drugs of the glucocorticosteroids are decreased, and budesonide is the favorite drug. We use a lot of budesonide suppositories and enemas in place of hydrocortisone. Continuing that, we really don't know about the full distribution of the glucocorticosteroids, but we do know of increased bioavailability, and sometimes the only manifestation of steroid toxicity in the older population is not the anticipated one, but it could be just in confusion, mental status changes, and you have a person going to psych without realizing what you're doing with the drug. There's, of course, the GI bleeding, infection and mortality, and another study that came out just recently from over 1,000 patients that continued steroid therapy worsened outcomes, increased anxiety, sleep changes, depression, fatigue, and was resulting with a lower anti-TNF use in this population. 6-mercaptopurine, azathioprine, is impacted by allopurinol, ACE inhibitors, 5-ASA, as I told you, increase the metabolites, particularly with an increased BMI and the 6-MP dose. The adverse events you're all aware of, we'll touch on briefly. Cyclosporin, as you know, is metabolized through that different system, and it is worsened with potassium-sparing diuretics. A study we did, a small study, looking at the effect of 6-MP in a community practice, and if you look at the bottom line, they found that there was an increased number of adverse events in the elderly taking 6-MP, but didn't touch statistical significance. Those of you who are increasing your use of methotrexate, be careful. There increased mortality with coexistent cardiac and renal disease in the elderly. It increases warfarin, NSAID's impact on methotrexate, and it cross-interferes with loop diuretics. And of course, the usual anticipated side effects. And always, always remember to add folic acid. So now we come to anti-TNF and we make decisions about the balance, whether we want to have less disease activity, less surgery, versus the adverse events. I ask you to think very carefully about clinical trials. They are not meant to give you information on the elderly. They're highly exclusive. Age is often an excluding. You have to be an Olympic champion often to get into some of our clinical trials. And in this age range, it's definitely a contraindication. They're not powered to study the elderly, and they're certainly not powered to give us information on those in the 60 to 70 or 80-year-olds. What we do in our practice is we'll wait a year after a drug is launched before we'll prescribe it to our older patients. And it's because we're so dependent on post-marketing data. You remember the side effects of COX-2 with cardiac disease. So the anti-TNF distributed very slowly, 9 to 14 days half-life. You can anticipate greater AEs, a congestive failure if you have a New York Heart Classification of 3 or greater, and hepatitis infection, melanoma slightly, and that's just recently been challenged in just last week, and I'll show you here, and psoriasis or psoriasiform reactions. When the Mayo did their first 500 patients, they had 5 deaths, and 4 of the 5 were elderly. And when they looked at their SAEs, their serious adverse events, almost all of them were over patients over the age of 60. But, and here again, they did not see an increase in malignancy. And that's of great benefit to us who have to treat patients with concomitant neoplasia. They have longer, in the European experience, they have a lower short-term response, but once they're on the drug, they have a similar long-term benefit. The serious adverse risk factor was greater. Again, in one case thought to be irrespective of glucocorticosteroids, but when you looked at the surgery and hospitalization rates with anti-TNF, almost invariably was not related to the malignancy, but related to the immunomodulator or glucocorticosteroid. And of course, the increased infection. Termination was greater with these drugs, and often there are a number of social reasons for that. In the US, we have a treat study where age related to narcotics and steroids were related to mortality. In Japan, their comparable treat study also showed the effect of age over 50 and immunomodulators. In a study of 143 patients, with 82 younger patients, again, less ileocolonic disease and definitely less biologics. In an 8,500 study, again, incredibly low use of anti-TNFs. In the study, which was recently on use of vedolizumab in the elderly of 130 UC and 90 Crohn's patients, they had lower serious infection rate, fewer adverse events, and no age differences. So it seems to be a safer drug in this population. This is just released just in the past few months. The phenotype in this elderly population was again colonic, but look at the second line. Over half of that group of patients were still on steroids. Let me just go back one. The use of Humira in the elderly in over 327 patients. As you can see here, there was some increase in their non-melanotic skin cancers, neoplasia, but their lymphomas were restricted primarily to a younger age group. Similar efficacy has been shown in biologics in the elderly, but less efficacy with immunomodulators. And here's a study showing veto in the elderly. In this particular study, they had a disappointing response with decreased values, but no greater adverse events. Now look carefully at this now. When we talk about infection with the biologics, I implore you to think that pneumonia is the major killer. It's not the lymphoma, it is not the TB. And if you look at the factors contributing to pneumonia, it is primarily the corticosteroid and the use of narcotics. C. diff, you'll hear more about in a few moments, is associated in the elderly with a higher colectomy rate, hospital stay, and in-hospital mortality, and invariably it affects the elderly. So when you're dealing with a drug in the elderly, remember that you have to think of all the confounders which we've just covered, and invariably the response will be muted by increased hospitalizations, morbidity, and increased cancer risk. As far as adverse events go, and here again, we're making the point, much of what we seek is vaccine preventable. And over 886,000 admissions to this country were due to pneumonia, flu, UTI, and shingles. And among the vaccines, you have to be very actively involved with your primary care provider in understanding that annual flu, the pneumococcus, the new vaccine, zoster, and I'll tell you about that in 1 second, hepatitis A and B, and the tetanus. Now, I prepared this painful slide, bringing you up to date that despite the fact that they were giving zoster vaccine to patients who are immunosuppressed, they did not have an outbreak. This whole slide you can just throw out because GlaxoSmithKline just released a dead zoster vaccine. So we're finished worrying about live vaccines with zoster, and we can go ahead and immunize our immunocompromised patients with the dead vaccine. Okay, still caution. Okay, fungal infections. Remember, when one of your elderly patients on immune suppressives or biologics becomes sick with what you think is a simple pneumonia, don't waste too much time with the PCP. Try and get a pulmonologist or an ID person to see them because invariably you're going to run across patients where they have histoplasmosis mimicking a community-acquired infection as well as other fungal disorders. Now, in looking at all the literature with malignancy in anti-TNF, that there's in a meta-analysis of 21 studies and the TREAT registry, but here when you dissect out the azathioprine and 6-MP, in all of those studies, the culprit was really the immunomodulator. The cancer data compared to the general population, as you see here, the overall cancer risk in this population was not significant. Immunological cancers were slightly elevated, and it's the only study I've come across which showed that there was no thiopurine as the culprit, but they've had no increase of colorectal cancer. And giving you an idea of where we stand with colorectal cancer, in the elderly, the cancers on immunosuppressants have a higher risk of metachronous cancers and at an earlier stage. And secondly, the cancer survival was lower in that population. In this one, this is the a study from the NICO group in New York that I mentioned to some of you earlier, where they looked at over 180 patients and found no difference at all in new cancers or recurrent cancers in patients who had cancer and were treated with biologics or immunomodulators compared to control groups without those agents. So that's very gratifying and giving us a new option to treat. As far as the malignancy goes, and speaking of lymphoma, the cancer risk, as you see here, was an age-independent risk factor, exposure to thiopurines, and in the French study, the greatest risk was in the elderly. And currently, we have no real test to prognosticate who's going to develop this. Non-melanotic skin cancers, very common with thiopurines, and you see the risk is considerably greater than age and sex-matched control, but advanced age is the greater vulnerability. And you see the French. So if thiopurine user, 4 per 100,000, past thiopurine user, no prion user the least. Once you use this drug, it's there forever. It's embedded in the DNA. You stop the drug, it still goes on its merry way and can produce basal cell cancers and squamous cell cancers. So you have to offer considerable help and sun protection and annual dermatologic examinations. Melanoma, you heard earlier this way about a slightly increased risk with the use of anti-TNFs with odds ratio. Now, just this past week, there was a Scandinavian study that will be brought out showing that there was no greater risk of melanoma. That's just another study. However, dermatologic exams, sunscreen, and the usual prevention mechanisms. Getting on to what happens when you're elderly in the hospital, 1% of all IBD patients who underwent an endoscopic exam will perforate, and that is primarily the elderly women under therapeutic dilations in the older age range. As far as post-op mortality, multiple comorbidities, of course, increase it, and if they have more than 3 of the Moore-Charlson comorbidities, they have an 8% mortality. Factors associated with it, as anticipated, the malnourished, renal, coronary artery, obstructive lung disease, and sepsis. In this Canadian study, the risk of surgery and mortality was such that the ulcerative colitis elderly had a higher rate of surgery. This had no difference from the young, but the Crohn's patients had a higher mortality, but the UC mortality didn't change. So what are we saying? That we have no difference in disease progression in the older patient. Surgical rates when correlated were similar. Disease was similar. Older Crohn's patients have higher remission rates in certain studies. And under treatment with biologics in the elderly, they risk loss of control. So what I'm saying to you is, if you think you're helping your patients who need biologics by not giving it to them, you're letting the disease go uncharted and along its way, and we're going to increase the complication rate and make it harder to treat them. And so under treatment with biologics in the elderly literally risks loss of control and increased complications. As far as factors impacting it, remember your prescription and your therapies are quite different for this couple than for this gentleman and for the one I showed you earlier. As far as management strategies, just a few take-home points. And don't rely on your patient's iPhone. Do a simple thing. Take an index card, let them list all the medications on one side, all their doctors and diagnoses on the opposite side. Laminate the card and keep it in your pocket so they wind up in the ER or some, first med place. It's right there, and there's no groping around for what happened. You have to maintain the medication lists at all your visits. You have to look at everything they're taking. You have to have the second listener. You must not let an elderly patient come alone. It's true, actually, for all patients. Come alone to the office. You need a second listener, and you have to write out your prescription and your directions. And it has to make sure that you've uploaded your healthcare maintenance. The instructions should be quite clear, reviewed by your staff, and reviewed by a second listener. So what do? We want to restore bowel function, improve the quality of life, induce and maintain a steroid-free existence, avoid them, get them out of the hospital, and keep them out of the hospital, and keep them away from corticosteroids. So the management is, as you said, and these are the same last slide that I started with. And to go back to Sir Thomas Sydenham, let's not do too much harm. Thank you.